Hello everyone, I am Dr. Mayur Agrawal, DM DNB Endocrinology from Bhopal, Director for Hormone India Bhopal.
How does Imeglimin fit into your regular practice with the current landscape of T2DM treatment option? Kindly share your experience.
Yes, so this is a newer drug which acts on through the mitochondrial pathway. We know about it. Earlier, we were very skeptical to use it because, see, it was not in, it is still not in the guideline that where actually you will place it. And usually, right at the beginning, we would use it when the patient refused to take insulin. So it was like an rescue drug which was used because mostly the guideline says that you have to start with lifestyle management, then you have to add metformin. Then, if the patient has some ACD risk factor, accordingly, you may add a GLP-1 receptor agonist or an SGLT2 inhibitor, then the patient may be on some other drug. So initially we used it as in rescue therapy where the patient was not willing for insulin, and during which we saw that the drug was acting very well, and it was initially in the Japan. We know about the times trial, all those. So this is a novel approach of diabetes management, and now we see that even in between also we are placing. There are data for monotherapy in the times 1 trials. It is approved, you can use it, but not at right at the beginning we are using it. But yes, we are using it as an add-on drug. It works via the mitochondrial function. It enhances the insulin secretion, and also it increases the insulin sensitivity. It decreases your, inhibits your hepatic glucogenesis. So all those actions are there, and it's a good drug, I would say.
In what specific patient populations do you see the greatest benefit of using Imeglimin?
Yes, so as I've already mentioned, what we are seeing that across spectrum you can use this drug, whether you talk about using it as a monotherapy, which was in your times 1 trial, or you talk about as an add-on to some other OHA, which was in your times 2 trial, or you use it as an add-on to insulin, which was your times 3 trial. So in practice also you can use it anywhere. Mostly in my clinical practice I place it where the patient are especially intolerant to my this metformin, where I usually use this drug. And we see that those patients who are already on insulin, if you're putting this drug, even if you're putting at a lower dose, then also there is decrease in the insulin requirement because it increases your insulin sensitivity and the patient responds better. Also, what we are seeing that the glycemic variability, that is up and downs in the sugar, that is also slightly decreased because there is decrease in the insulin resistance, improvement in the insulin sensitivity. Your overall treatment, that is improved. Overall HbA1c is better controlled. So overall the outcome, the rate of complication would decrease. So uncontrolled hyperglycemia with multi risk factors, with metabolic dysfunction, especially if the patient is GI intolerant to metformin, that is where I would like to place this drug.
How does Imeglimin compare to other hypoglycemic agents in terms of safety and efficacy? Kindly share a real world case if you have.
So as I told you that we are using in n number of patients, it is totally safe. You will not see that something other drugs are getting the metabolism is changing. Overall the insulin requirement reduces, the glycemic control is much better. There is no side effect in terms of your weight gain or in terms of your hypoglycemia, provided you are adjusting other drugs, obviously. So this works via different mechanism, right? So it's a novel different drug, totally different class, and it has synergistic effect with other drugs. So you can use it with any drug, I would say, right? So you can use it in those patients who are drug naive, to those who are intolerant or who are on multiple drug, even on insulin. So right from beginning to the end, you can place this drug anywhere and you will get benefited.
In recent time, Imeglimin sustained release formulation with Indian study has been launched in India. What is your opinion on that?
Yes, so I believe both were okay, but with this you can say you can give once a day, also one time a day, that is better. Then maybe it has some GI less intolerance, but not very sure about that. But obviously the efficacy is at par whether you are using a sustained release or you are using an older version. It's almost the same. That is what is my take on this.
How does the mitochondrial targeting mechanism of Imeglimin influence its clinical use?
So see, this drug is acting via this mitochondrial function, which is very important for your cellular energy, for your metabolic regulation. So this is a different drug. It is targeting differently. So it can be used with various combination, and this may help beyond what your other drugs are doing, because other drugs what they are doing is just they are either they are secretagogues like your sulfonylurea. What they do is they act on the beta cell and make it secrete more of your insulin. More insulin is produced, but that is the problem with that they may lead to beta cell exhaustion. That is what we call as secondary OHA failure. And some other drugs like your metformin, pioglitazone, they are acting just on your resistance part. They are increasing the sensitivity. So this drug is acting on both the pathways. This mechanism is different. So that is why a combination, combining this drug with other drugs, will give you an add-on benefit. So this is the great thing about this molecule.
What are the key safety and efficacy findings from clinical evidences on Imeglimin that clinicians should be aware of?
So in my clinical practice, I would again emphasize that especially those patients who are intolerant to metformin. You see the structure, there is some similarity with the metformin, right? So especially those patients who are intolerant to metformin, they are very well were tolerating this drug. So lesser GI side effect is there, better tolerability than your metformin, and as I've already discussed in terms of efficacy, this is a very good drug, because you are adding in some of my patient, I am adding it after say 4 drugs. If you see the guideline, what they say that beyond 3 drugs, if you are going on to a 4th OHA, it will not work, right? The HbA1c will increase. That is the indication for you should be putting your patient on insulin. But as you would be aware and you would agree with me that most of your patient will never agree that they should be put on insulin, for the very simple reason because it's an injectable drug, and in at present also most of our patient will not be affordable for your oral GLP-1 analog. The oral semaglutide is available in India, so that is out, and then injectable is out, and the patient does not want insulin. So what are you left with? So in those patients, I have tried this drug and this gives wonderful result because of the synergistic action. This will mitigate your diabetic complication, all your metabolic complication would be reduced, and there are some data about the neuroinflammation, all those things. So that is also reduced with this drug. So overall, you can use it right at the beginning or during your treatment or when the patient is not willing for anything else. So ultimately, you have to give something to improve the HbA1c, to reduce it, to prevent the complication. So that is where you should be using. So obviously, it is efficacious. It is safe to give any of those patients.
Do you believe that Imeglimin has the potential to change the future landscape of diabetes treatment?
Okay, so that's a tricky question, I would say, because we cannot predict the future. But yes, it's a effective molecule. I would say it will change the future if it is introduced in the guidelines, because being a super specialist, and for any physician even, I would say now is the era of evidence-based medicine, right? So you can prescribe something which has evidence. We have evidence right now, but we need to follow guidelines. But obviously the guidelines are to guide you, you have to follow, and then you have to put your mind into it, right? So obviously we are using this drug, but once it is introduced in the guideline, we'll have more of data, we'll have more of real world evidence, and then exactly we would be able to say that where we should be putting this, and where the patient should be put this drug right at the beginning or in the middle or wherever. And then we need some more data. Especially I would love that if we have data on pre-diabetes. So that is where I think that this drug may even be a game changer. We don't have data at present, but that is my feeling, and that is what I would like, that we should have that data. So as the research will continue, more and more data would be coming, more and more information would be available. Maybe in the future Imeglimin becomes that a cornerstone, a major game player, major treatment part. It may be there because it's a totally different drug and no other drug is acting via this pathway. So we cannot exactly predict the future, but yes, this may be possible because of the new mechanism of action, and this drug can be used as an alternative therapy to whatever we have, and along with the existing therapy also you can use. So obviously it can be a game changer for diabetes management.
Any other key point or take home message you would like to give apart from this?
I think what we want at present is more of data. that will actually bring this molecule and overall management of diabetes. Because see, we Indians are totally different, genetically we are different, right? And our diet is different. So sometimes what happen, one drug which is not acting in western counterparts may be acting better in our population, and vice versa can also happen. So we want more Indian data, we want more of real world evidence data, so that will actually change the pathway, the treatment algorithm, that is what I mean. That will totally change the algorithm how we are treating patients.